how to approach a patient with acute chest pain. So acute chest pain is one of the most common presenting symptoms of the patient who present to the emergency department. And it has a broad differential diagnosis which includes some life-threatening conditions. And the most important thing in approaching a patient with acute chest pain is differentiating the patient who are having life-threatening conditions versus having benign acute chest pain. So this pie chart shows what are the causes of the acute chest pain. Most common is gastrointestinal, other are the cardiopulmonary. Cardiopulmonary causes are the life-threatening causes. Some may be due to chest wall conditions like having muscular pain, costochondritis, or herpes zoster is also one of common cause during the old age. These are the life-threatening causes of the acute chest pain. Most common is the acute coronary syndrome and pulmonary embolism, aortic dissection, pericarditis, or spontaneous tension. So, before going to the approach, first we should understand what are the what is the pathophysiology of the acute chest pain. Acute chest pain may be somatic chest pain or it may be visceral chest pain. Somatic chest pain means it is arising from the chest wall, or visceral chest pain means arising from the organs like heart, lung, or vessels. The somatic pain is sharp and it is precisely located, whereas visceral pain is imprecisely localized, difficult to describe, often aching discomfort type, and it may be radiate to the other part of the body. The most important thing in a patient who presents with acute chest pain is the history of the patient. We should first listen to the patient carefully, how he describes pain, what is the duration of the pain. That gives us 90% of the diagnosis. So history is the most important thing of the patient. Now we briefly discuss about the all life-threatening conditions. One is the acute coronary syndrome. It is the most common life-threatening condition in patients with acute chest pain. It occurs whenever there is a imbalance or there is a mismatch between the myocardial blood flow. When there is an imbalance between the supply-demand mismatch is there, and blood supply is less as compared to the demand, then patient is having ischemia, which can cause angina, and this angina is perceived as a retrosternal chest discomfort, which may be as a tightness, pressure, constriction, or squeezing types, and it may radiate to the left side of the jaw, left side of the neck, or maybe both arms, but it never radiates to the above the level of upper jaw or below the umbilicus. If a pain is radiating above the upper jaw or below the umbilicus, then it is unlikely to be because of the cardiac origin. So pain which is central, pressure type, squeezing, gripping, or heaviness type, tightness type, increase on exertion or stress related factors, or this kind of pain is more likely to be because of acute coronary syndrome, whereas pain which is sharp, fleeting, shifting, pleuritic, or positional, then it is unlikely to be cardiac in origin. What is the pathophysiology of the acute coronary syndrome? We all know that in our coronaries, atherosclerotic plaque is formed because of the deposition of the cholesterol. And atherosclerosis is a progressive disease. Progressively it increases in size and it encroaches on the lumen of the vessel. And this reduce in size of the vessel causes supply-demand mismatch, and whenever there is a increased demand of the blood to the myocardium, then angina occur. It is called stable angina because it occurs whenever there is a exertion is there, then it is a stable myocardial angina. But some patients may develop erosion or rupture into the intima of the vessel, and then this cholesterol or fat is exposed to the blood, then it leads to the formation of the thrombus in the vessel. And this thrombus may either lead to the subtotal occlusion of the artery or total occlusion of the artery. If artery is totally occluded, then it causes ST elevation anterior wall MI. ST elevation myocardial infarction, or if there is a subtotal infarction, then it may be present as either as unstable angina or non-ST elevation MI. So these are the type of the pain. What kind of pain? Typically pain of myocardial angina is dull type, constricting, choking, heaviness, squeezing, pressing type of the pain. Patient may also have associated symptoms like hypotension, oliguria, cold peripheries, narrow pulse pressure, or there may be features of the pericarditis like pain on movement or deep breathing may be there. These are the risk factors for the atherosclerotic cardiovascular disease like smoking, diabetes, hypertension, hyperlipidemia, family history, previous history of the ischemic heart disease, male sex, age more than 40, or another risk factor like having rheumatoid arthritis. Our young patients who take cocaine, they are also high risk of the acute coronary syndrome because of the spasm of the artery. Because cocaine is it reduces adrenaline in our body and it causes severe vasospasm in the arteries. So when we suspect that patient is having acute coronary syndrome, the first investigation is ECG. But ECG, it is not 100%. Always give a diagnosis of the acute MI because in 10% of the patient ECG may be normal. So patient symptoms are important. If patient is having typical symptoms, having retrosternal pain radiating to the left side of the jaw, having perspirations, having symptoms of the adrenaline crisis, having hypotension, tachycardia is there, then we should always suspect acute coronary syndrome. Maybe ECG may be normal. So we should treat patient as a acute coronary syndrome and we should do the serial ECG in these patients or cardiac biomarkers of the myocardial damage. In ECG, the ST changes should be at least two leads should be there, two contiguous leads. These are the ECG changes. I mean, there may be ST elevation or ST depression. So we see the J point. J point is the point between the ST segment and QRS complex. Then if this J point is shifted downward, then it is called ST depression. If it is shifted upward, then it is the ST elevation. If J point is shifted upward, then it is ST elevation MI. Otherwise, it may be unstable angina or N-stent. Second most important cause of acute chest pain is aortic dissection. Aortic dissection occurs when their intima of the vessel is there is a tearing into the vessel wall and intima is separated from the tunica media of the aortic vessel, and the false lumen is formed into the aorta and which suppresses or compresses the true lumen. And the pain of the aortic dissection is it is excruciating, very severe pain, ripping type of the pain which starts in the anterior side of the chest and may radiate to back. And it may be associated with symptoms like paraplegia, abdominal or flank pain, or patient may have stroke if it involves the carotid arteries. And the most important investigation for aortic dissection is CT coronary angiogram. CT coronary angiogram is diagnostic in these patients. And clinically we can suspect aortic dissection in patients if there is a discrepancy in the pulses of the patient or a discrepancy into the blood pressure of the patient. If upper arm blood pressure is high as compared to the lower arm, then or there may be a discrepancy between the two arms, then we should strongly suspect the aortic dissection. Pulmonary embolism is another most important cause of the aortic dissection, and it is mostly missed or misdiagnosed because its clinical presentation is very variable. Mostly it presents as a shortness of the breath or perspiration or pleuritic chest pain. It is also best diagnosed with the CT pulmonary angiogram. ECG changes in patients of pulmonary embolism may show right ventricular strain, or there may be typical S1Q3T3, means lead prominent S wave in lead 1 and prominent Q waves in lead 3 and T wave inversion into the lead 3. So S1Q3T3 is diagnostic of the pulmonary embolism. Chest X-ray in these patients may show dilated main pulmonary artery. Like in this patient, pulmonary artery is dilated on both sides. D-dimer test is the lab test which we can get in these patients. Otherwise, diagnostic is the CT pulmonary angiogram. Another important cause of acute chest pain is spontaneous tension pneumothorax. These patients also present with one side of the chest and their main complaint is shortness of breath. And chest X-ray is diagnostic in these patients. We can see there is no bronchovascular marking on the right side of the chest, whereas heart is shifted towards the left. Pericarditis with tamponade is also important cause. It means inflammation of the pericardium. These patients are having pain on deep breathing or coughing, and the pain is get relieved by the sitting up or leaning forward. And ECG in these patients shows diffuse ST elevation in all leads except a lead AVR. Lead AVR there is ST depression with PR segment elevation, whereas all other leads shows ST elevation with PR segment depression. So now I'll show some ECGs. These are the ECGs of patient with acute coronary syndrome. Here we can see ST elevation in lead 1, lead V1, V2, V3 with reciprocal ST depression in inferior leads, lead 2, 3 and AVF. So this is ECG of the acute ST elevation anterior MI. This is also ECG of the ST elevation anterior MI. Here we can see in lead V2, V3 there is a biphasic T waves. This is called valence T wave pattern, and it is also suggestive of almost subtotal occlusion of the left anterior descending artery. In this lead we can see there is a symmetrical T wave inversion in anterior precordial leads from V1 to V6. These symmetrical deep T wave inversions are also very highly likely give diagnosis of the anterior MI. Here we can see there is ST elevation in lead 2, 3 and AVL with reciprocal ST depression in lead 1 and AVL. And this ECG is suggestive of inferior wall MI. It is also ECG of posterior wall MI. Here there is a significant ST depression in lead V1, V2, V3. And if we take right side leads, then there may be ST elevation. So this ECG is suggestive of posterior wall MI. In this ECG there is a right bundle branch block with T wave inversion into the lead V2, V3 and V4. And this ECG is suggestive of acute pulmonary embolism with right ventricular strain pattern. In this ECG we can see there is alternate difference in amplitude of the ECG. It is ECG of electrical alterance. It is suggestive of large pericardial effusion. So these are some basic ECGs about the which patient with acute chest pain patients can have. So how to manage these patients with acute chest pain, especially if a patient is having acute coronary syndrome. If we are suspecting that patient is having acute coronary syndrome and ECGs are normal, then we should keep the patient into the observation and serial ECG should be done for the interval of 10 to 15 minutes. And tropi can also be done in these patients if there is a doubt about the acute coronary syndrome. Then these patients should be stabilized as ABC, acute airway breathing and circulation. And if there is a desaturation is there, then when we can give oxygen in these patients. And these patients, if there is a strong suspicion of acute coronary syndrome, then loading dose of the aspirin, ticagrelor or clopidogrel should be given to these patients. Aspirin should be given 300 mg with clopidogrel is also 300 mg. If we give ticagrelor, then it should be 180 mg, or prasugrel, then it should be 60 mg stat. If the patient is having signs of heart failure, then we should not give these patients, fluid should not be given to these patients, and instead, according to the BP, we should give them Lasix, stat dose of the Lasix. Acute chest pain is one of the most common presenting complaint into the patients who present to the emergency department, and these patients have broad differential diagnosis, and some of these may be licensed into these patients. And our main aim is that we should not miss these life-threatening conditions. And ECG is a very important diagnostic evaluation. It should be done as soon as possible. And if there is any doubt, then we can give done the profile or can send the patient to the UV cardiologist or wherever we can see. Thank you.